That's the other name for total hip replacement. For those of you who are interested in a little trivia there. My sister-in-law, she fell and broke her hip. Oh, there's another good reason for having a total hip replacement right there. Fracture. Well, we were thinking it wasn't bad to require it. Do I need to keep this open?
You want this is
Or do they hear me otherwise?
well, you can draw on back phone on your computer.
Oh, okay. So are people actually hearing me? Okay. I am glad you are here.
Yeah.
Oh, cool. Speakers, headphone. Okay, audio. Ah.
I thought it was very yeah, I'm still taking it. Yeah.
Well, it isn't on mute, right? Should be picking up my voice. I'm just worried about people in Zoom land maybe not hearing me at all.
Are you guys on Zoom able to hear us?
Yeah, we can hear you, no problem.
Oh, okay. Thank you. Let's see. How do I get back to slide 1? Oh, heavens. Okay, there we go.
Right here.
Oh, very good. Okay, so making this big again. How do I make it big again? Right here?
Press on 3 dots, maybe.
Okay. Oh, there we go. All right. Okay. Sorry about the delay, folks. Just wanted to make sure everything was, everything was proper and you could hear me, etc. So right, total hip arthroplasty in me. I just recovered from total hip arthroplasty. It was done on the 30th of May. It's a little over 3 months ago, roughly. So want to talk a little bit about what causes hip joints to deteriorate or get to the point where they need to have surgery. Okay. Okay, I am guessing here. Let's follow the arrow. Okay, total hip arthroplasty, also known as total hip replacement. All right, so what is it? Probably the latest, greatest form is what you see in the picture here. The surgeon will remove the diseased head of the femur. As you can see here, hopefully my head is not blocking the way. This is where your femur, the head of the femur, is normally located, okay? And this is normally the articulating joint space under normal conditions. And then you have all kinds of tendons that crisscross muscles, etc., ligaments, etc., that go around that area to form the joint capsule. So what the doc does is, depending on the approach, I had actually from the front. So the doctor made an incision at the top of my thigh through the front. Okay. And that's how he's able to access the damaged hip. So what he does, and what he did before in my pre-op sessions, he showed me the fancy prosthetic I'd be getting and how it would fit in. He says, here it is. This is how it moves around. This is what it looks like. And this is what it's, this is what you're going to wear, or this is what you're going to have inside. So th yeah, I know. Do I get a warranty? No. Well, he guaranteed that guaranteed. Well, he says if everything wears normally, you'll probably have about 25 years on this hip. I thought to myself, wow, that's a lot more life than I would get on the tires of my car. So, or the engine for that matter. So right here is what you would call, this is the joint space or the acetabular fossa. And this is the acetabular component here, this cup. Now the cup has an inner lining to it, and it's made of a special type of plastic. Okay. And what happens is that once the head of the femur is removed, a femoral stem with a femoral head or a ball is put on top. And those pieces are then put together, and that becomes your new joint. For lack of a better way of putting it, that is your new hip. Now, that's a total hip replacement. There is such a thing as a partial hip replacement, and it's called a hemiarthroplasty. And what they do usually is they remove the head of the femur like they've done here in the picture. And they leave the socket joint alone, provided it isn't diseased by arthritis and there isn't too much cartilage worn down. So that's a partial or a hemi. There's usually less blood loss, smoother, quicker recovery time with a partial. They put in a slightly larger prosthetic head simply because they have, for the total hips, they have the joint capsule and the prosthetic go together. Okay, so it's made in such a way where they're not going to put a larger head size into a smaller joint cavity. They already have those pieces put together, and that's what the doctor uses. So, and actually too, with the partial, the larger joint head that they put in there actually allows for greater mobility in the sense that it will still maximize the amount of surface area that's left up here. The part where it makes contact and movement and rotation, etc., with the hip. So this is the various types of approaches in the total hip replacement process. You can see the pictures at the right, how this is done. This one appears to be done from the side because that is an option. There are actually three options that are common. There's through the front, through the side, and through the posterior, which is the back side. So what the surgeon and what you as a patient are most concerned about is, after surgery, the possibility of dislocation. Now, probably the greatest possibility of dislocation is with those individuals that have the procedure done from the posterior, because more muscle and tissue is cut away and separated in order to do the procedure from the backside. And so all of that has to be sutured and placed back together again. And it creates a weak spot for a while. And so the possibility of dislocation becomes greater because of that. Now, the direct front approach that I had has about a 0.6 to 1%, which is pretty good. But it cuts into the fewest number of tendons and muscles as possible, which is what I favored in the end anyway. And the recovery rates are really good. And I can sit down and get up and walk and I have fewer restrictions because I went that approach. And luckily, I got set up with the surgeon who could do all three. But I chose the frontal approach. That's the option I wanted. Now, the lateral approach has a very low dislocation risk, 0.3 to 0.6%, which is very good if one opts to have it done from that position. Now that I don't know what are the percentages. What are the percentages of those who have it front, lateral, or posterior? That was a number I didn't bother to look up. A number also that's concerning to both you and your surgeon is the risk of infection, because it is a very invasive procedure and there is a small risk of infection. And it's somewhere around the 0.2 to 1.2% in the first couple of months or weeks following the surgery. And so this is why the doctor and or his physician assistant or nurse practitioner emphasize keeping a good eye on the surgery site, watching vital signs, things like pain, any wound drainage, redness around the wound, spiking of fever that can't be explained any other way other than, hey, I just had surgery and look what's going on. The satisfaction rates, at least through NIH, are between 89 and 95%. And I'm hoping I'm in the 95 percentile. That's where I put it right now, because I've had a very good recovery. I'm at 3 months. It takes roughly 9 months to a year for a full recovery, but it depends on what kind of shape and condition you're in. Age also factors into it too. You could have a very uneventful recovery like I've had, which is good. I was up walking same day as surgery, discharged the next day before noon or slightly around noon. So I stayed one night over. Most people, they discharge the same day if they're up walking around, but I requested one night over. Yes, pain and trouble moving. Mostly, yes. And the trouble moving smoothed out considerably because of the arthritis. And that's the reason I had the surgery in the first place. I didn't have a fracture. I did not have cancer or any kind of disease process. I had severe arthritis, which left me with very little cartilage left inside the joint space that holds the head of the femur, so I can move around and move that leg around. And so that was a relatively late discovery. I did not discover that until almost 2 years prior to the surgery. And this had been bothering me for a long time. And I had attributed it to something else. I had attributed to back pain because it was hitting along the same pathway as my sciatica and radicular pain from my lumbar spine, which also has had surgery. Another story for another time. So I had gone into the doctor's office. The doctor who put the spinal cord stimulator in to mitigate pain. I said, look, I'm having all kinds of discomfort on this right side. And I said, I want to make sure that all the wires are in place. So they put me through a x-ray of the hip, different views. And they didn't know how to, because I was talking to the PA. He says, this doesn't look great. He said, you ought to talk to your physical medicine doctor about the results on this. And so I had the CD. I went over to see him, And he says, you have no cartilage left in that hip. This is where your pain's coming from. This is where your trouble with movement's coming from. And that was approximately 2 years prior. This is 2021. So it's, when I finally saw the surgeon, he says, oh, this has been going on for years. You just probably didn't know it. Why would you have had, an x-ray there, especially when you assumed it was back pain and due to your back surgery, which she says your back is a mess, but I'll leave that to my back specialist colleagues. So anyway, arthritis. I had so much extra bone growth on the femur. It was not normal looking. And it was no wonder it was grinding away at all the cartilage that was lining and around the joint space. It was nearly all gone. The one risk that I was scared of the most with the direct anterior approach, the DAA, was some nerve injury that turned out to be transient, thank God. And it's because when they're in there moving things around, pulling the femur out in order to do the surgery and kind of jostling things around, it hits a couple of the femoral nerves in front. And what it did is I had a lot of cutaneous, which was skin pain, almost like shingles type pain, nerve pain that was on the surface. And anytime I got up and moved in the first few weeks, it was difficult. Luckily, as the weeks went on, that pain started to disappear. With some people, it doesn't. And that's sort of a risk you take. So, when I mentioned it to the doc, he says, this is perfectly normal. Says, we irritated some nerves. Says, this is very normal. It's something that's a hazard of doing the surgery on this approach. It's each approach, he says, here are the risks, benefits and risks. Which one do you want me to do? So I opted, yeah, basically. So I had a very good response through the front. He was very pleased, in fact. When he saw me on my first post-op a month later, he was surprised how well I was getting up and moving around. I told him I drove to the office. He says, then I know I told you no driving for 6 weeks, especially since you had this done on your right hip. He said, as soon as you get home, no driving for 2 more weeks.
Excuse me.
Yes, I did.
I have to catch my transportation.
Oh, yeah. Take care. Good to see you, Ben.
I'll see you again.
All right. This will probably be recorded or
But
put up
I
on the site.
want to one question before I leave.
Yeah.
I have a friend that passed away on a hip injury because he had hemorrhage
Ah,
and he died of hemorrhage.
okay. Bleeding.
Bleeding, yeah.
Bleeding is also another risk of having a surgery like this, because there are a lot of nerves and blood vessels that surround and invade that area. So
He was found by himself.
oh, well, did this happen before or after? Did he fall and broke a blood vessel that way?
After the operation.
Oh, after, okay.
Yeah, he was sitting in his wheelchair and, he was not moving, but he was already gone.
He was gone. I'm sorry to hear that.
Okay, I'll see you.
Yes. Well, bleeding is also, I want to say, a risk after the surgery. And also blood clots, unfortunately. So I'll get to that. I'm going to move through these slides a little bit quicker here. But you can see how invasive this is, even from the side. The surgeon actually pulls out a bone saw, cuts it off, And then when he puts the prosthetic in, he has to drill a hole into the femur. And then he has to make sure it's big enough to put the prosthetic into, and he has to. And same thing with the joint space. He has to clean all that out, literally clean it out. And then he has to make more holes to fix the new prosthetic. Yes. Okay. I got there super duper early in the morning. I had to check in at like 4:45, 4:30. I was in surgery at 7. When I woke up in recovery room, it was it was after 12 noon. It was when I made it to the room after recovery, it was after 1. So it was somewhere in the ballpark of 4 hours, plus or minus a half hour, because when I got into the surgical suite, the surgeon and his tech's assistants, they had to set me up a certain way to do the surgery. So I had to be propped up in a way and strapped in a way that he does this surgery or could do the surgery the best way possible, greatest advantage, etc. So I spent a while in there before they put me under. I heard all the chatter, the talk, et cetera, et cetera. Anesthesiologist is right behind my head. The surgeon is on this side. His techs are around him helping to, so there's a lot of people moving around in the room even before the surgery is started. So, oh yeah, every aspect. I mean, I had intravenous, I had IVs going already. Everything's stuck to fingers to monitor oxygenation, hooked around here even before they put me under. So it was quite a process. And they swung me into the suite roughly around 7, maybe slightly before that. Because the surgeon always comes in and says, okay, are you ready for this? And I told him, I said, I couldn't be more ready, Dr. Ty. Let's do this and get it over with.
Pain preparation, you have a patches or.
Okay. I knew how much pain I was going to be in because I talked to a number of people. Also, they sent me brochures. One of them was the size of a small booklet of what to expect before and after, the kind of nutrition I had to put myself into. I had to drink supplements like crazy 3 times a day for 5 days prior to the surgery. Nothing that thins the blood for 2 weeks prior to the surgery. No aspirin, no naproxen, no ibuprofen. He said, afterwards, here's what's going to happen. We want you to take aspirin twice a day, baby aspirin, which I did 30 days, starting the moment after the surgery, almost, when I was able to swallow pills in the bedroom after I'd been moved from recovery to the room I was going to be in overnight. Start a baby aspirin regimen twice a day for 30 days. They offered me a heparin shot, and I said no.
That for surgery part?
Well,
Yes, that's what
it's a preventative measure after surgery for people who've had, and depending on how long, I think the doctor was not taking any chances. If I was going to spend more than one night, he wanted to make sure that if I was going to spend a couple of days there, that I got heparin. And I didn't. And so I said, no, I don't want the heparin. I'll stick with the baby aspirin. But I was very happy that I spent one night over, because the pain that night after they'd given me a block, which numbed me up prior to surgery. And the surgeon kept asking me in the surgical suite before they put me under, okay, how's your sensation? Can you feel anything below your waist? How's that going? And he'd ask me periodically until I was completely numb. So I knew once that wore off, I was going to be in for it. And for the first couple of weeks, it was quite painful. And I was very glad for the pain medicine, and I was very glad for ice packs because I used them over and over and over and over throughout the day into the night. Anytime I got up and moved and sat down, anytime I got up to moved again, laid down, ice packs came with me right over the surgical area. So I would say after about 2 weeks, things started to improve. But that cutaneous pain, that surface pain, took a few weeks longer to disappear. And by about week 5 or 6, it was gone. I was using lidocaine patches over those areas. That's how bad the surface pain was. And it's just skin, like an electrical or burning pain. Anyone who's had really bad neuropathy knows what I'm talking about. And it was right in the area, right around the incision. Of course, I didn't put it over the incision. It was just the area around it. So anyway. But I do not regret having had the surgery. Now you can see this. Take a look at the x-ray really close. See, this is the right side. Here's the left. This is the right side. This is the one I had replaced now. This isn't my x-ray, but this is a reasonable facsimile. You're supposed to see a lot more space between the head of the femur and the joint. There should be a lot more space there, and there isn't. There's very little space there, which means there's very little or no cartilage. Now, it's hard to see, but you can see a little extra bone growth, maybe some bone spurs around this area. The only reason why I know that is I've looked at enough x-rays to kind of identify what looks like a bone spur and what looks like extra bone growth. The most common, I have it yellowed out. Osteoarthritis or arthritis in this region is the most common reason for having this surgery. By far the most common. It's somewhere in the ballpark of 90% of the time. This is the reason why. I mean, there's others. Rheumatoid arthritis is also another form of arthritis, but it has other factors that bring it on. Same with this osteonecrosis, which is associated with trauma. And it may be if you somehow weaken the area or you break something or you're on steroids for a long time that weaken the bone and something happens there, necrosis, they call it osteonecrosis, a dying of the tissue of the bone can occur. That's another reason. And now this is what is arthritis? You can see in the picture on the right where arthritis can occur, and that is by no means all the places arthritis can happen. This is just a sampling of where arthritis commonly occurs. And I know Linda's had total knee replacement, both knees. I'm not sure if she had it due to arthritis, but I wonder if she did. Anyway, osteoarthritis, it causes the cartilage, which is the slippery surface bone has, to move on. It makes it easy to move. So, bone over bone is to have that cartilaginous surface there. And it covers the ends of bones, which is great. It's a beautiful design. And where it covers the ends of bones where they articulate and meet, there's usually a joint there. But it's not so great when it breaks down. Yeah. Now, from some sources, breakdown due to arthritis can happen due to as much as 100 conditions or different types. And I looked at that number and I thought, holy cow. Each one of those probably needs a PowerPoint of its own just to talk about why you know, the arthritis is what it is there, and how did it come about? Again, most common reason why surgeries are done in some of these major joints, like the knee and the hip. Some people live with them for a long time and it doesn't bother them as much. Others, first sign of pain and first sign of arthritis, you know, things kind of go downhill. They have to have something done about it, you know, soon. And usually with arthritis, the most common signs and symptoms are swelling somewhere in and around the joint. That could be here at the wrist, could be at one of the metacarpals, metatarsals, could be at the knee, could be in the ankle, could be at the elbow, shoulder, hip, tissues surrounding that area. Redness is not uncommon, or it is common, excuse me. Stiffness at the joint, that is something else that I had quite a bit of before the surgery. And mobility gets altered. I remember telling the surgeon that one telltale sign is that sometimes when walking, the joint or the hip would hesitate for a moment and then I could hear click. So it had moved, which isn't normal. And he says, well, that's a good indication that, you know, you've got troubles there. And the arthritis probably on the head of the femur that catches, and that's where the clicking noise comes from. It's audible, you could hear it. Someone else with ears right next to me could hear it too. That's how loud it was. Crazy, huh? So this is a really good picture. I wish I could show you mine, but I didn't have access to it. This is a very reasonable picture. This is roughly what mine looks like. And it's kind of cool, although it doesn't look like they put a brand new hip surface in here. This looks like they put in a replacement hip with a very large head. This might be a hemiarthroplasty is my guess. Because typically you'll see the head in at least some part of the new joint space. Now, if you look at the other hip on the other side, this one looks arthritic too. It looks pretty big, but this thing looks huge compared to the head of the femur over here. But that, you can see how far down the femur they have to pound this thing in, and they have to get it just right. And you know why? Otherwise, you have a leg that's slightly longer or shorter than it was before. And so all these measurements and things and, you know, getting it just right are other things. You know, he says, well, you might end up with a slightly longer or slightly shorter leg. And he says, this might make your back problems better, or it might make it worse. Oh, luckily I knew the surgeon. I used to work with him at Sutter General. So, but he says, you know the drill. He says, nothing is 100% certain on these things. And he says, you have a lousy back. And I said, I'm sure you've been told that even with a hip procedure like this, that it may or may not make things better. And I said, I'm well aware, Dr. Ty. I said, but I'm also want to do this 100%. So I was bound and determined. So, you know, here's a couple other things. Cancer can invade the region, unfortunately, and that's, in this case, it's called chondrosarcoma. It's a cancer that begins to eat away in the area of the cartilage of the joint. And it is usually secondary, I want to say second most common primary bone cancer. I'm not a cancer RN. I've been there many times floating, but there's primary and secondary causes and traveling cancer as well. This is the second most common primary bone cancer. And it is the kind of cancer that travels and can move to other areas of the body.
That is with all joint, diseases, or they,
Well,
saying hip.
with hip, but yes, this specifically with hip. Now could it, a form of chondrosarcoma also happen in another joint? Possibly.
Well, I've had shoulder and knee replacement.
Mhm.
So that's why.
Well, it's something you'll know when the doctor identifies it on either an X-ray or MRI scan. Exactly. Well, you know, it was something I was unaware of, but I knew cancer, bone cancer, is pretty hideous. So, this is one of the reasons why a hip might be replaced. Hip injury, and that would be due to impact, a fall. Improper healing of an intervention like a hip surgery might also lead to further hip injury. I want to say anything from a dislocation. I've seen x-rays of very, you know, unbelievable hip dislocations where I would look at it and I'm just kind of amazed that it looks the way it does. And I imagine the deformity, how it looks on the outside, looks even worse. But, you know, complications due to fractures, falls, impacts, you know, Ben, who mentioned having a friend of his or an acquaintance having had the surgery and bled, there's always secondary injury as a possibility. And, you know, this is one reason why, too, they said, you know, watch what you're stepping on really close. Don't hyperextend. Don't do. Here they sent me home with a don't do and do list. And then make sure you're taking the baby aspirin twice a day. Do not skip a dose. Do not take it for 30 days. So I thought I adhered very closely to that do-don't list until I got a new do-don't list when I saw my physician for the first post-op visit. Yes.
You had Senate Center?
Yes, I had it done at Sutter downtown. And I already knew the surgeon. He had a very, very, very good reputation. Even when I worked there, I worked on the neurology unit right down the hallway from orthopedics where he was. But he came to our unit a lot of times because a lot of his orthopedic patients needed some sort of neurological or some sort of treatment on neurology, either afterward or before or something of that nature. So I knew the surgeon pretty well. And he had actually consulted on my shoulder surgery before sending me to another surgeon who just does shoulders and shoulders only. You know, he says, I could do it, but he says, I think this doctor will do an absolutely marvelous job on it because that's all he does. And he knows shoulders really well. So I consulted with him on that. So I trusted him really well. I still do. If I have to have the left hip done, he'd be the one to do it, provided he doesn't retire first. He's getting up there in age. Now, statistics associated with total hip arthroplasty replacement in America, at least up to 2010 by age and sex. So under 50, that looks pretty good. Under 50, the rates are about the same. After 50, the rates for men go up a little bit, but so it does for women too. When you figure women have to deal with osteoporosis, it's not that men don't. They have a problem with it too, or can, but women more oftentimes have that problem than men. But you can see as you go down, as you go up the age ladder, numbers change a little bit and they stay kind of even until we get to around the 70-ish. And then women start to climb up a little more in the number of hip replacement surgeries. And I don't know if this is due to whether it's, I would say there's probably secondary bone problems that are occurring. I don't know how prone men and women of the same age group, how prone are they to fall or have falls? And what are some confounding factors like eyesight, bad proprioception, use or lack of use of canes and walkers, collisions, any kind of collision. I don't know what some of the other confounding factors are that contribute to why women have, 1.5 to 2 times more. But in the case of this history one, became quarters, so she had just little paths in the apartment to get around because if she tripped and fell over something. Tripping hazards, okay. Yeah, so she had so many that when the fire department came, they told her she couldn't come back to the apartment until they got cleaned up. So that we've been doing for the last 3 weeks. Yes, tripping for whatever reason as we get older, falling for whatever reason as we get older seems to be a problem. Unsteadiness, problems with vision, hearing, you name it. It falls under the category of what changes as we age. And there's a whole bunch of things that change as we age. And men and women are impacted in different ways by, becoming older, aging, the aging process. That's really what it is. Now, here's some numbers between 2012 and 18. Total hip procedures reported to this particular journal, AJRR. American, for heaven's sake, joint replacement. It slips me. Crud, I wish I could remember. They put these abbreviations in because the names are like this long. But according to this, primary or first-time hip replacements represent 80.5% of the procedures done. Of the 602,582 hip replacements done between 12 and 18 of this new century. New procedures, revisions of total hip replacements represent 7.3% of those numbers that we're looking at. The hemi-arthroplasty numbers, or partial for hip fracture, represented about 8.2% of these hip replacement surgeries, these hip surgeries in general. Total hip replacement for fractures represent 2.2%, and hip resurfacing procedures about less than 0.9 or less than 1%. So you can see it fits into a myriad of categories, but the biggest is the first-time hip replacements, which is where I fall into, first-time hip replacement. So there's a link here that could help you locate some of the latest annual reports on joint replacement surgeries in America, including some of the other joint surgeries. I don't have any numbers for Europe or Canada or any other country. I just focused mainly on America because this is where we live. So the link below that follows the market projection of joint replacement surgeries through 2028. We used to call Sutter General, well, not call, but we used to, it just seemed as if the hospital favored orthopedics because it was the meat and potatoes. That would be spine surgery and joint surgeries. The hospital made an awful lot of money off of those, at least Sutter General did, because they weren't a heart surgery center. Joint surgeries, yes, a lot of joint replacements, meat and potatoes, making a lot of money. I just wonder what those numbers look like projected through the end of this decade. I didn't bother to look. So again, here's another picture. You see on X-ray, you can see some of the components that differ, but you can see that encapsulated piece is separate, and you can see some of the screws that fixate it into place. And this is just another look at the same thing, basically. And to me, it's when I saw mine for the first time on X-ray, I could hardly tell I was looking at my own hip. It was wild. I said, "That's my hip, huh?" He says, "That's it." He said, did you take any other pictures? I asked him. He says, "No, this was quite enough to tell that everything was in the right spot." I said I was hoping for an overhead, a side, and a posterior. Yeah. But I was quite satisfied with what he had done. And it looked a lot like this, even though this shows a procedure from the left hip. All I can do is look at this in amazement. That's all I can do. Now, what's the pre-op look like? And this is going to be slightly different depending on the surgeon for each and every one of these. And for knee replacement surgery, it's going to be slightly different. Every time you have a joint replacement, depending on the joint, you're probably going to get different pre-op and post-op orders. It's a given. But what happened for me, I had the referral to the surgeon, X-rays, follow-up X-rays, MRIs, no CTs, but some doctors will sometimes ask for that. I had steroid injections because I had to wait a long time to have the surgery. And the injections worked, which was a clear indication this was not a back issue, because after the injections were in place, I had relief same day. So that's not the back, definitely the hip. I was taking all kinds of non-steroidal. Best stuff I was taking was the ibuprofen. I took, the doc wanted to offer me Norco, and I said, nah. I said, not unless it gets really bad. So I declined on that. Did I get PT and OT? I did get to see PT and OT, not the OT, but the PT a couple times prior to surgery. And then I got 3 months worth of PT after surgery. Now, CBT is cognitive behavioral therapy. Some people need that to deal with everything from pain to, just change in motion, etc. And what a very serious surgery like that can do to you. Some people benefit a lot from the CBT when it comes to pain control, I've heard. Now, postoperatively, narcotics. When I was in the hospital, I got both narcotics, muscle relaxers, and I got a non-steroidal drug given IV, and they were around the clock. Sutter was very good. But I think because they knew I was a former nurse there, they took better than usual care of me. And I knew a lot of the nurses that brought me in through post-op, revived me from anesthetic. As soon as I was revived, I ran into two former students. What are you doing here, Professor Mitchell? And I'm groggy in and out. I had my right hip replaced. It was weird. But I knew a couple of the nurses on the unit that accepted me for my overnight stay. And so they were around the clock. If it wasn't a pill, it was an injection for pain. Boom, 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 boom. So they're very good at taking care of pain. Post-operatively, I couldn't take any non-steroidal drugs because I was on aspirin. And that could lead to significantly increased chances of bleeding. So doc said, we'll give you what you need narcotic-wise, otherwise Tylenol and ice. Worked out beautiful. So yes, all of that. Rest, ice, lay off, elevate, worked great. Incidentally, after the surgery, something I already knew, but I just didn't know how this would look until after surgery, is that I had a lot of swelling. Swelling went down my leg and all the way into my ankles, and pretty soon I had bruising down there, even though the surgery was up here. I knew blood was finding its way down into my feet. And it looks like I had, slammed my toes and my foot on something, caused bruising. I knew this was just blood simply collecting from uphill. And, that took a while to go away, but it's 95% gone. So it was weird. They do all kinds of blood work to make sure you're A-OK, 12 lead EKG. Again, lay off of any type of non-steroidal drug, aspirin, at least 2 weeks prior. They put me on Ensure, immunologic surgery recovery support drinks. I had to drink 3 bottles a day for 5 days prior, and then 3 bottles a day, or 3 bottles a day for another 5 days after the surgery when I got home. It was funny because I wasn't used to drinking milkshakes like that. And then, of course, prior to surgery, I had to bathe for 3 nights in a row and the morning of in an antimicrobial wipe called chlorhexidine, head to toe, focusing on the hip, but head to toe, basically. So that's a regimen. It's like, you got to do these things. You have to go get this done, get this done. You have to do it in a timely manner. Did you pick up your pre-op this? Did you just have your pre-op that? So recovery, I'll tell you, everybody recovers different. It follows a certain pattern, but length of time is different for everyone. Some people experience pain a lot longer. Some people, it takes them longer to recover mobility. Some people have complications for whatever reason. And that also, I believe, has something to do with the approach, because I could sit on anything I wanted to after surgery. I could get up as soon as I wanted to after surgery, due to the approach I had taken. I can't say that for everyone else who's had it from a different approach. Likely they had different precautions. But the one thing they want you to do is move. I talked to a colleague of mine at UCD, there's a nurse on ENT floor over there. I said, how'd it go for your husband? She said, everything went great. I asked her, what advice can you give me, prior? She said, walk. As soon as you can, as much as you can tolerate, walk, move. I took it to heart. So, yeah, I said 8 to 12 or 9 to 12 months, depending on the surgery and your condition, you might go a little longer, up to 16 months. And edema, as I mentioned before, is an expectation. It's not something to be scared about after surgery. It's natural to have swelling around the extremity and down the leg. And that's why they say, elevate it, put ice on it, elevate it, elevate it. Exercise as much as you can tolerate when you can tolerate it. Ice it afterwards, which is what I did ritually speaking.
Severe Depression. like-
No, only on the night, only on the overnight that I stayed there. Now, compression stocking. I'm glad you brought that up. The reason being is I had purchased a set. I had tried it for a couple of nights, and it was so uncomfortable to be wearing that stocking. Middle of the night, I had a pair of scissors by my bed and I just cut it off. Because I couldn't bend forward and pull it off. I cut it off, and then I had to nudge my wife to wake up and cut the rest of it off. I said, I can't wear this anymore. Simply, I just cannot do it. I said, I will take the extra edema and tightness. I'll just put an extra pillow underneath there and let all the extra edema and fluid run back where it's supposed to go and back into my circulation. I'll take the risk. Speaking of risk, don't take any unnecessary risks.
Don't do as I do as I say.
Yeah. Well, I gave my hip a tryout back in July when it was okay for the doc. He said, you can try uneven surfaces. So I did. My wife and I went to Bodega and we were walking trails along the Bodega Bay coast. There was an area about roughly a mile into a 2-mile, 3-mile hike that I simply couldn't go beyond because it looked like part of the trail had been washed out.
Why didn't you just walk on the beach?
Well, that occurred to me, except that, some of the steps down to the beach didn't look all that great. I was afraid of slipping and finding myself doing the tumble. I said I'd much rather, if possible, walk on a surface that's, near road level. So we did, and I walked on uneven surfaces tolerated until I got to the washed out point. Walking in other areas that were wooded, there were trails, was just fine. No problems there. It was great. Now, scar tissue also is something that forms. But as I worked with PT, the therapist I had worked me pretty hard, working my joint through scar tissue. Says it's just a natural process in healing. You're going to have it. Says, let's work your way through it because you're going to have to get joint mobility back. And, I want you to practice this when you're not here, et cetera, et cetera. And I did. So each and every time he saw me, he said, you're looking better, you're looking better, you're looking better. I think the advice I give anybody is use your common sense after surgery. If something looks risky, don't do it. That's my best advice. Yes, if you're wearing those stockings. So any questions? I put some other questions down there. Does age make a difference? Condition, like I have all these other conditions going on, heart and bone and whatever. Age can have an impact on how fast you recover without complications. Just depends on what kind of shape you're in. That's really what it comes down to. I've seen a lot of older individuals, 70s, early 80s, hip replacement. They're up walking around because they're used to playing tennis or they're used to doing something else, bicycling, hiking. And so their condition prior to going in was really good, commendable, good shape. And I think it made a difference for them coming out. And that's why in the year leading up to the surgery, I did everything I could to try to get into and stay in the best shape I possibly could. And I think it made a difference overall in my recovery period. Plus, I was motivated. Motivation makes a big difference too. I want to get better. I want to get better. So, I mean, weight and mobility can have a factor in different ways. I mean, if one's mobility is already hampered and they happen to injure that same area or joint, it might make difficulties coming back to baseline that much more difficult. If somebody is too heavy and they fall and getting around perhaps is already difficult, it might make recovery period longer. And I don't, mean that in a bad way. I just mean that getting mobility back and joint strength and muscular strength, and I want to say motivation, it just may be a little different for those individuals. Doesn't mean it's impossible. Obviously not. A lot of individuals who maybe have a little bit too much weight, I've seen them do pretty good coming out of surgery. Some of them very motivated, some of them actually more active than you think. What about heart disease? What about diabetes? What about chronic lung disease? Those are factors. These are things that have to be kept under control best you can. And as long as you and the doctor and your primary physician are satisfied with where you are and controlling those other issues that, also require your round-the-clock attention, and they're well taken care of, your process through surgery shouldn't be hampered that much. Is it worth it? To me, it was. To me, it was. Everybody has to weigh that. Yes.
I didn't have any problems. The worst part about it was taking a shower.
Ah, yes. Okay. I'm glad you mentioned that, hygiene. Because I wasn't allowed to scrub, rub, or wash. I want to say wash around it with any vigor until the wound had completely healed, which meant the strips that were holding the wound together had completely fallen off, and that whatever was underneath, which should be well approximated and together, if it isn't, that's when you have to start having trouble with infection. You have to wait until that part that was underneath those strips or whatever. Some people have closure with staples or sutures, whatever the case may be. You have to wait until that wound is completely healed, then you can scrub, rub. Otherwise, you have to let soapy water run over it and pat it dry. That was the one thing you could do. You could let soapy water from washing up above, etc., run over that area and then just rinse it and pat it dry. And then keep a close eye on it.
Shoulder replacement.
Oh,
She had she was worried about the scar.
sure.
And We started rubbing vitamin E oil on it, got an infection.
Oh, yeah, don't rub anything on it. Oh, Kevin.
She didn't want a scar, you know. Visible scar, so. On 80 at the time, so.
Well, I have to be honest with you, after mine completely healed, I started putting a little aquifer ointment on it because,
But see, yours was completely.
yeah, it was completely healed. I waited and waited and waited. Right. I waited until there was nothing. I mean, it's like I waited to the point where I could run a washcloth over it. And then I just, with a Q-tip, I ran a little aquifer over it.
What is that?
Well, it keeps, for me, as it was continuing, the scar, Dr. Ty told me the scar would go through its own evolution until the color changes. And he says the skin around it looks, you know, a little less pinched. Says it might, you know, everything might be nice and well approximated and healed, but you might get a little pinch or a dimple. Says that will also flatten out over time. And so I waited and for all of that to happen. And then I applied the aquifer in order to kind of, what is it? Well, it also helps with scarring. The only reason I know that is the tattoos I've had, I used aquifer on it. And aquifer was the preferred lotion, medicated lotion. It's used so many ways.
That's big stuff.
Yeah, the aquifer, and then I slapped, you know, they have a special wrapping they put around that. So, but aquifer is multi-useful. It's great. You can use it on so many things, but not on open wounds. Yeah, I can understand your mom wanting to like rush things. So
If you're 80 years old.
you're in.
don't worry about scars.
Okay, I know.
Gonna wear your strapless.
Right, exactly.
Oh my gosh.
We would call and dance for right up until near the end.
Wow.
So she would wear all pants, so cute. She was worried that
Somebody would see.
the scar, so that would limit her ballroom gowns. So, yes, I know.
Any questions out there in Zoom land? Did I do something?
Thank you, Dave.
Did I end something
Kevin.
without, Kevin, see you.
No.
No questions? Theodora? Is it Leanne?
No
Any
questions, no questions, but great presentation as always. Thank you.
Oh, thank you. Appreciate that. I'll just go ahead and end the presentation.